Hi, the following content is for educational purposes only and does not constitute medical advice. If you are a healthcare provider, please consult with your affiliated institution or local ethics committee for ethical guidance related to clinical practice.
Hey, BioE 131, this is Russ, and we're doing a technical briefing, Module 3 on precision medicine. And I just want to give you a little introduction to kind of what they're doing technically so we can think about it when we're talking about the ethics. The general idea of precision medicine is, of course, to learn how to make specific diagnoses and specific treatments for patients based on all of their physiological and other data, as opposed to kind of a one-size-fits-all medicine or there's only a few choices and pick the best choice type medicine. So one big theme of precision medicine is connecting health data to genetic data. Now, that's not all of precision medicine, but that's a big theme in a lot of the projects. And by health data, I mean electronic medical records, wearable, Fitbit, Apple Watch type stuff, and maybe even environmental sensing of exposures, and relating that to genetics, which could be genotypes or SNPs, which are specific locations in the genome that you can measure. You can easily Google genotypes and SNPs if you don't know what I'm talking about. Exomes, exome sequence, which is the sequence of the expressed genes in the genome, and then whole genome sequencing, where you just sequence the entire 3 billion bases, one from mom, one from dad. But the idea, not to lose track, is to relate the genetics to the health data, including environmental exposures. Okay, so that's at least part of precision medicine. And there's two things I want to talk about in this briefing. And I'm going to talk about it in terms of my own research interests, which are in pharmacogenomics. Pharmacogenomics is the study of the genetic influences on drug response. So when I give a drug to a patient as a doctor, I have a good idea what happened, but they don't always respond to the drug in the way that I'm expecting, and that's because there are differences. One of the differences is due to their background genetics, and so pharmacogenomics is trying to understand how the genetics of a patient might influence their drug. And the two main things that we do, not only in pharmacogenomics, but in all of genetics, that I'm going to talk about is GWAS and PheWAS. So let's just quickly get into that because I don't want this module to go on forever. So GWAS stands for Genome-Wide Association Study. And what you're doing in GWAS is you're asking, what are the genetic influences on a phenotype of interest? Genetic influences on a phenotype of interest. Now, in my work, the phenotypes that I might be interested in is whether a drug works or whether it causes a side effect. A main reason why patients don't take their drugs is because they have bad side effects. So if I could predict this patient is going to have a side effect, I might use a different drug. So let's say we're doing a study. This is going to be a GWAS study. And what we're going to have is 500 patients who have the side effect and 500 patients who didn't have the side effect when they were given some drug. Now we're going to look at genotype at a million different positions in the genome, where there in general are two choices of the A, C, T, G bases in the DNA. So a negative GWAS, this is a negative study, would look like this. Let's make a little table. These are the 500 who have the side effect. These are the 500 that don't have the side effect. That's an S. And we're going to have at a position in the genome, let's say it's position, chromosome 7, position, 53, 531. There's millions of positions, but let's say it's position 531. And let's say at this position, you either have an A or a T. You get one from mom, one from dad. So you might have, there's three choices. You could have an AA, you could have an AT, or you could have a TT. In the case where mom and dad both gave you a T, or mom gave you an A and dad gave you a T. Now, in a negative GWAS, you would see, let's say, 100 AAs, 200 ATs, and 100 TTs in the people who had the side effect, and you would see the same, within statistical reason in, and here I made it exact, in the ones who didn't have a side effect. That tells you that this position, let's highlight it in red, this position does not matter for that side effect. It's a negative result because knowing the genetics had absolutely no predictive power over whether or not you had the side effect. Now you can imagine, I hope, what a positive GWAS would look like. In a positive study, you have your same study, you have your side effect people and your not side effect people, and you have a little grid, and you have your AA. Well, let's say this is a different SNP, right? Because we already showed that chromosome 7 position 531 is no good. So let's not confuse things. Let's say this is now going to be position chromosome 9 in position 7,281. Okay, different SNP. And let's say that that is a GA SNP. The two choices are G or A. So you would have, I put that in a bad spot. Let's erase that. Let's make it G or A at this position. So you might have GG, GA, or AA. And let's say in that case, you get 10 here, 100 here, and 290 here in the people who have the side effect, but you get 100 here, 200 here, and 100 here. Now that is a positive because of the huge difference that you notice that having an AA, having an AA gives you a huge risk for this side effect. You are 2.9 times more likely to have the side effect if you have an AA than if you have the others. And in fact, if you have a GG, it's protective relative to, because the GG is much more common than people who don't have a side effect. And there's a lot of other statistical things we could say that I'm not going to talk about. But that is the idea. What makes it genome-wide, so I'm going to highlight genome-wide, is that we do this test. Here I showed you one negative position, one positive position. But in a typical GWAS, we are doing that test on like 1 million one time. Oops, that's not going to work out. The thing that makes it genome-wide is because we're checking 1 million locations across the entire genome. And we're looking for any position like this one that has a positive association. When you see a GWAS, they often plot it as follows. They have all of the positions in the genome. I said 1 million positions divided by chromosome. So this is chromosome 1, chromosome 2, chromosome 3, all the way up to chromosome X and Y. And they have the negative log of the p-value, where the p-value is a measure of the difference, of the certainty that the side effect and the not side effect groups have different statistics. Because, they may not be exactly the same, but still close enough that you say they're not different. And when they're different, you have to quantify how different they are. And that's through a p-value, which you may learn about in statistics. And there's usually a cutoff where you have to be above some level to be impressive. And a GWAS has, when they report it, they often report it, I'll do this in blue, as what is called a Manhattan plot, because most of the positions are not significant. So I'm going to draw a bunch of blue dots. But then we know that, like I said, chromosome 9, so let's say this is chromosome 9, there's going to be a spike, and there'll be a series of locations there that are positive, and then it goes back to being negative. Maybe there would be another positive spike over here, and so then you get your Manhattan plot, because these are like skyscrapers. I didn't invent the name, but that's the idea. So people want to get lots and lots of patients in these precision medicine studies so they can take all kinds of phenotypes. In this case, the phenotype that I was interested in was side effect or no side effect, but they want to do for hundreds of phenotypes, diseases, drug response, disease risk, drug response. They want to see where are the genetic associations so they can predict them for patients. So that's the first kind of study in precision medicine. The second one is PheWAS, which is a very cute idea that just flips GWAS over. So let's talk about PheWAS and then I'll finish. So in PheWAS, these are called phenotype-wide association studies. So whereas a genome-wide association studies is looking at 1 million SNPs across 1 million positions or locations in the genome across the whole genome, in a phenotype-wide association, what they're looking at is one position in the genome. So this is one genome position that varies. So like a G or an A, or as we were talking about before, one genome position that varies. They're still plotting the negative log of the p-value, but what they're plotting against are every different phenotype in the medical record. And a phenotype is a trait or a characteristic, like their body mass index, whether they have diabetes, whether they have arthritis, whether they have glaucoma, their height, and many, 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 many other things that you can pull out of an electronic medical record or from a wearable. What is their maximum heart rate? What is their minimum heart rate? All these things that you can measure about someone are all the phenotypes. And then if you have the genetic information for 1 million people, then you can say, okay, for all the people who have diabetes, okay, and if I look at this genomic position, do I see an association between having diabetes and having a certain variant at this position? And if there is an association, it gets a high score, a high negative log p-value. But if it has a low one, for like if at this particular position BMI is not affected, it'll be low. And so most of them will be low. It's going to be like a little bit like the Manhattan plot, but then a few things above some threshold will be positive. So in order to have a phenotype-wide association, you have to have genetic information, so you know what at each position, what genetic information is present for each patient, and then you need to know for the patient all of these diseases and whether they have them or not. This is interesting because sometimes you have a SNP that's a hit for diabetes in a GWAS, and then you do a PheWAS to see if it's related to any other diseases. So in the case that I just made up off the top of my head, I am suggesting that diabetes and height share a genetic influence, and that might have a profound meaning in terms of implying that maybe the genetic circuits that determine whether you have diabetes might also be involved in determining height. I totally made this up, so do not get excited about this association. But when people do PheWAS, they do see unexpected phenotypes, both coming up positive for a single genetic location, and that makes them think, oh, that genetic location in some way ties together these two phenotypes. So these are two things that are done for precision medicine. They both require lots of genetic measurements, like a whole genome sequence, which is what many of these biobanks are headed towards, and they require lots of phenotype data about the patients. Both of these can, of course, be abused, and that's why we're talking about it in an ethics class. This is the end of the module.